Hello, I'm Dr. Eric Bergson, and I'm going to talk to you a little bit about something that's called recurrent laryngeal nerve monitoring. This is an important part of thyroid and parathyroid surgery. It's a tool and a device that we use to help make thyroid and parathyroid surgery safer. Anybody who's having thyroid or parathyroid surgery will get a preoperative discussion, like anybody having surgery, about the risks of surgery. One of the main issues that we deal with thyroid surgery is that there's a nerve in the area that we call the recurrent laryngeal nerve, which is what controls or provides innervation to the vocal cords. So I'll just explain how that works just a little bit here. Here you have the thyroid gland, and here we have what's called the larynx or the voice box. This is the trachea, and here we have on either side the recurrent laryngeal nerve. I'm going to zoom in on that in just a second for you. So like anything that moves in your body, the vocal cords move because your brain tells it to move by sending a message along a nerve. If the brain were up here, there's a big nerve that comes down the side of the neck between the jugular vein and the carotid artery. This is called the vagus nerve. The vagus nerve comes all the way down almost to the heart, and it makes a U-turn and then sends off a branch that you can see right here. This is called the recurrent laryngeal nerve. And you can see there's one on this side, there's one on this side. This is the trachea, and this nerve comes up and goes into the voice box. Now it's worth taking a minute just to point out what's inside the voice box. What we have are the vocal cords, and I will zoom in on this in just a second for you as well. But you can see here we have the left vocal cord, here we have the right vocal cord. Looking through there, we see the rings of the trachea. This is the vocal cords in the open position, and this is the vocal cords in the closed position. Again, open and closed movement because of messages sent between the brain and the vocal cords. So when we're doing thyroid surgery, this nerve is coming right underneath the thyroid gland, and it's something that we have to be very careful about. Every operation, we want to identify, preserve, and protect the recurrent laryngeal nerve. And that is probably the most important step of the operation. Injury to the recurrent laryngeal nerve is extremely uncommon, occurring with an incidence of less than 1%. The consequence of injury to the recurrent laryngeal nerve, albeit a rare situation, is trouble with mobility and motion of the vocal cord on the affected side. So instead of having good opening and closure, you could have one vocal cord that does not move properly, and this can have, of course, an impact on the voice. So when we do thyroid surgery, we can use what's called a nerve monitor. A nerve monitor basically works as follows. Anybody undergoing general anesthesia for surgery is going to have an endotracheal tube or a breathing tube going down into their trachea to provide breathing while they're under the anesthesia. In order to get into the trachea, a breathing tube needs to sit and slide right between the vocal cords. And because of that, we're able to use a special breathing tube, endotracheal tube, that has a little sensor on it. And the sensor sits right at the level of the vocal cords. This allows us to perform this nerve monitoring technique, whereby what you do is you identify the nerve and you touch the nerve with a little stimulator, which sends a teeny electrical impulse up the nerve to make the vocal cord on that side twitch. The twitch will be detected by the sensor, and it's connected to a monitor on the side of the room, which will essentially make a beeping noise. And that tells you that the whole neural circuit is working properly. So you can use the nerve monitor to, we call it, map the nerve. In other words, before you visually identify, you can use the probe to simply just touch a few areas, and if you get a beep, it gives you a hint that that's the area where the nerve is, and then you can proceed with direct definitive identification touch the nerve again, make sure that that indeed is stimulating and corresponds with what your eyes and your brain tell you to be the nerve. And then, very importantly, is after you've removed the gland from one side, you can then go and touch the nerve again to make sure that you still have your stimulation, your beeping noise coming from the device. This is crucial because you are very unlikely to really injure the nerve during thyroid surgery, but it can happen. But however, a temporary irritation, inflammation, or a temporary, the medical word is neuropraxia, meaning that because of the manipulation of surgery, because of the push and pull, maybe a little retraction or stretch, the nerve becomes irritated, inflamed, and temporarily does not work properly. This is analogous in a certain way to what you might experience if you've ever taken a nap, laid on your arm in the wrong way, and then your arm doesn't move properly. This is a process, neuropraxia, that will recover to normal in just about all cases, although it can take a few weeks. So, even if you visually see your nerve after removing the first side, visually seeing that the nerve is intact does not 100% correlate with adequate nerve function. And therefore, the nerve monitor is a nice way to be sure about the function of the nerve. This is crucial because if you have a neuropraxia, if you have a temporary dysfunction and weakness of the motion of the vocal cord, that's going to be frustrating for a patient. It's going to take some time to go back to normal, which it will in almost all cases. There'll be an impact on the voice, but it's not a disaster. It's more of a frustration and a nuisance that you just have to wait it out. However, in the unlikely event that this were to happen again on the other side, this would be much more of a significant problem, because if the vocal cords are stuck in a closed position and the person is unable to open the vocal cords, they're going to have trouble breathing and very well may need a tracheostomy, which is where you have to make an opening in the trachea, insert a tube, and have the tube come out from the skin. Otherwise, this person's going to have trouble breathing. Now, that, of course, is a problem. It's a huge quality of life issue. It's just not what anybody wants. Many thyroid conditions are benign. Thyroid cancers are cancers that can be treated, over time. We know that they tend to grow very slowly. There's no urgency to this. So the last thing we want is for somebody to have a tracheostomy, even if it's going to be temporary. A tracheostomy for 3 months is just not something that anybody wants to have. It's a problem. So this use of the nerve monitor allows us to do what's called staging the operation when needed, meaning that after you remove your first side, you touch the nerve again. If you don't get your stimulation, if you don't get your beep, in many cases, most cases, we would do what's called staging the operation, which means we would stop at that point, even if we had intended to remove the other side. And we would just allow time to go by, whether it's a week, a month, 2 months, or 3 months, and we can monitor the function of the vocal cord by using a little scope in the office. And when that vocal cord returns to normal in its function, we can then go and proceed safely to remove the other side. And by doing this, by using this nerve monitor, we can essentially bring the chances that a person ends up with a tracheostomy as a consequence of thyroid surgery just about to zero. There are, of course, extenuating circumstances, reasons why you might not stage a procedure, certain very particular issues that may be going on with an individual patient. But for the most part, staging an operation is a completely reasonable and safe thing to do. And again, it allows us to proceed and perform these operations in a safe manner. Many people will tell you perhaps that they don't use the monitor, they don't need the monitor, they know where the nerve is or what have you. And that's I think often going to be the case anytime there's a new technology. Not that this is all that new at this point. It's been in common use for at least 10 or 15 years. Yes, nothing replaces experience and clinical judgment. We all know where the nerve is. We all know what the nerve looks like. But And you're never going to rely on a device blindly. You're not going to stimulate something that you know does not look like a nerve and say, oh, that must be the nerve, of course. But at the same time, it's a tool that can be used to perhaps find the nerve faster than you might otherwise have found it. Use it in the way that I just described to be sure that physiologic, functional integrity is there, even though you've seen physical integrity of the nerve, making sure that functionally, so that you can safely move to the other side. There are also times where the nerve may have unusual branching patterns, and you may say, oh, look, I've found the nerve, but not realize that, oh, that's just one branch, and look, that's not stimulating. Now you go and continue your look, and you see that there's the other branch that's actually the motor branch. Sometimes the nerve can branch to what we call a sensory branch and a motor branch. So it's a tool. It's a tool that I use on every case because I think that it is just another way that we can perform these operations in a safe, thoughtful, and logical fashion. I have a picture here of some of the instrumentation. You can see the setup here. This is the monitor. This particular device is made by Medtronic. You can see there's a screen, and there's some adjustments that you can control with the settings of how much voltage and sensitivity and whatnot. Here now you can see a picture of the endotracheal tube. You can see just above the balloon, or the cuff we call it, you can see the little electrical silvery tape. That's the EMG monitor, and there's some wires that come out from that and are plugged in. The endotracheal tube is otherwise exactly like any other endotracheal tube, and that's how we use it. So this is a closer look here. Like I had said, you can see here we have the thyroid gland, the voice box. Here's the jugular vein and the carotid artery with the vagus nerve coming down. And then as we come all the way down, the heart would be here. You can just see there's a branch coming off here and coming back up on either side of the windpipe, one on either side. This is the recurrent laryngeal nerve coming up underneath the thyroid gland and going into the voice box. And then just in this shot, I was talking about the vocal cords. Again, here we would have the left vocal cord, the right vocal cord. Down through there is the trachea. Here we have the vocal cords in an open position, and here we have them in a closed position. So I hope that is clear, and thank you for your attention.